So you have to track the cycles of each individual woman to understand what phases. You have to collect the data within each different phase because it changes the neurophysiology so significantly that it's a whole different subject, essentially. Mm-hmm. You could say every woman is essentially 4 different research subjects over the course of a month. So you want to get data from each of those subjects.
Right.
And then you want to go over at least 3 months to cover 3 cycles. So again, you can see how things are getting more and more complex and very, very expensive now. Very expensive.
Welcome back to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Scher, and it's a pleasure to be back with all of you. So this is a fantastic episode to record with my friend, Dr. Kayla Osterhoff. Here is a bio on Dr. Kayla. So she is a neuropsychophysiologist and a women's health expert, best known for her research and innovations in the field of women's health. Formerly trained across the health sciences spectrum with degrees in health ecology, public health, epidemiology, neuropsychophysiology, and mind-body medicine, Kayla has dedicated her career to advancing women's health science through a holistic understanding of female biology. Having previously held senior positions at the CDC, Kayla collaborated closely with global health leaders such as the WHO and the Ministers of Health to develop and implement major health initiatives and craft public health policy. However, driven by her desire for more flexibility and recognition and limitations within the corporate and governing structures, Kayla embarked upon an independent path. In her pursuit of transformative research and health policy reform, Kayla founded her Biorhythm, a platform dedicated to addressing gender disparities in health research and education. Her unwavering commitment is directed towards reshaping the landscape of health, research, and corporate policies. Kayla's vision focused on fostering inclusive approaches that not only promote health, but also contribute to the health of our planet. And Kayla's been a friend for many, many years, and it was such a pleasure to be able to speak with her. This is the first time that I had spoken to her when she had gotten her PhD. She'd been working on it for a long time. So I got to address her as Dr. Kayla Osterhoff, which was very, I think, amazing. And so much gratitude for what she's doing in this world for women, especially as I am married to one. I have 3 children myself. And we had a really great conversation here. Kayla and I spoke initially about how women have been neglected and taken out of research, both as a result of just gender disparities in general, but also from actual laws that prevented women from being involved in research back until the 1990s or so. So we spoke about the massive disparities there with research, randomized controlled trials, all these different trials that have been done. Most of the time, women are not involved, even to this day, because they're difficult to study. We spoke about the difficulties to study women as well in detail. And we talked about also the gold standard way of working with women in a study. Now, this is not easy, but I'm amazed at what Kayla has been able to accomplish here and having basically 3 set categories of understanding how we need to work with women in research studies. Everything from knowing their cycle to how we're collecting data within their cycle, within hormonal phases, to how this data is reported and much more. So we then transitioned to talk about Kayla's time at the CDC and how she found that a lot of the programs that they were working on, cardiovascular programs, are working for men and not for women. This is what actually got her out of the corporate side of things and got her more into the advocacy and the work that she's doing with her Biorhythm and others. She is a great educator with great understanding of this disparities in healthcare when it comes to women and women's health. But she also talks about how women in the workforce, especially on the medical side, the key really is that flexibility leads to inclusivity. And she says that a number of times during this podcast, flexibility leads to inclusivity. We also talk about how women are basically for women through their menstrual cycle and how things shift from a neurochemistry perspective, from a brain perspective, from a cardiovascular perspective. We talk about these key differences, both mentally and physically, not only during the cycle, but for men and women as a gender gap in that perspective, and how the differences in gender truly are a part of this hormonal matrix that women are always cycling through. So this is a really fun podcast to record. I really hope you enjoy this episode with Dr. Kayla Osterhoff. If you do like it, and if you like our podcast, don't forget to like and to subscribe below. We really appreciate you sharing the podcast with your friends, families, and colleagues. Enjoy the show. All right, Kayla, good to see you.
Good to see you as well. Thank you for having me on the pod.
This is fun because I think this is the first time that we can I can formally say, Dr. Kayla Osterhoff, it's so great to see you. And congratulations on everything you've been able to accomplish. I mean, you are somebody like me that likes to do a billion things at the same time. And I know you worked on your PhD for many, many years. And I'm really excited to be able to now delve into all of this that you've been working on so hard and bringing to the world from your perspective over the last years. But now that you're doing this full time and working with governments and politicians and working with so many people in between and people that have children like me and trying to help, today is a really great opportunity, I hope, to show a lot of the practitioners and the other people that are listening the amazing work that you're up to and doing. So to start off, I wanted to start off with the main thing that I was just shocked about, and a lot of practitioners don't even know this, is sort of the history of women being involved in research studies and maybe some of the history of how this all kind of developed in the last 40 or 50 years, because I know you're an expert in this, and I think it'd be great to set the stage as we talk about some other stuff.
Yeah, thank you. And thank you for offering an opportunity to share this important information, because I think one of the biggest issues we have in our healthcare system and our political systems is just a lack of awareness around some of the issues that specifically women face and some of the limitations that we're working with on a societal level. So when it comes to research, which is kind of the core issue of all the other things that we're going to talk about later on the podcast today, and the reason why this is a core issue is because we are currently in the age of information. We use data and information and research to build all of our policies and systems and infrastructures and protocols and everything else. This is how we develop our world today. And so it's really important to understand the database or the information base from which we are working from, which happens to be very male-centric, very skewed male-centric. The reason why that happened is because starting from the beginning, the advent of research, of scientific inquiry, which came in the age of enlightenment, right? I don't know how many thousands of years ago. I'm not a big history buff. But following the age of agriculture, we had the age of enlightenment, and mostly men were involved in that field of study, of education, of scientific inquiry. From that point, and for the next long time, another like 1,000 years or so, it remained to be mostly men in the field of science, any area of science, really. And so we fast forward to today, and we have a research system and database that is still primarily focused on men. And I'm going to explain why this is the case. Starting in the 70s, we had a formal ban of women from all scientific research, all clinical trials. And that formal ban, which was administered by the FDA in the United States, United States is the leader in research and how research is conducted. So kind of whatever the United States does, the rest of the world follows. When the FDA banned women in the 70s, that remained in effect for about 20 years into the 90s.
Can we discuss real quick, Kayla, what was the reason for the ban at the time?
Yeah. So the reason for the ban was that women are risky research subjects. And that's because we can potentially become pregnant. And so any women who were actively cycling were formally banned. And what this actually ended up being was all women being excluded from scientific inquiry, which was not a new thing. Women were already excluded from our research prior to this.
Right. So even before, it was actually not even the case that you'd find women in research, correct? Okay. Right.
Yeah. So women were already not being included in research. Then they made the formal ban just to make it illegal, essentially, to include women because it was too risky. It was an ethical issue, is what they made it. But the truth is, the reason why women were excluded from research before that was, yes, that was a concern, is that if women become pregnant during the study, how is the intervention going to affect them? So there were real concerns around that. Right. However, the reality is something else. The reality and what we're understanding now and starting to learn is that women are a lot more biologically complex. We have a lot more moving parts happening. And that's because of our ovarian hormone cycle.
Right.
And we'll get into that. But because there are so many more moving parts, it makes studying women extremely difficult, very time intensive, and very resource intensive. So essentially, in order to study women, it takes longer and it costs a lot more resources and it's a lot more complicated and requires a different level of expertise, all of which people are not willing to pay those costs in order to get their data. So now we look at the landscape today. Since the 90s, the formal ban was overturned, but women today are still not included in our research for the most part. We're starting to include them a little bit more, but really, for the most part, the vast majority of research still excludes women for the same reason, because we are expensive to study and it takes too much time. In the world of data and research and in the age of information, what do we all want? We want fast, cheap data. As fast as possible, as cheap as possible.
And the
only way to really do that is to study male subjects. So even when we look at our animal studies, previously and today, we still use primarily male subjects because even our female animals have the same complexity, which is very difficult to control for. Those are really the main reasons why we have not included women in our research and why that database that we built our society upon is very male skewed in terms of
right. And so we're talking about and this, I think just from a perspective, when I went to medical school and we learned about, studies on these cardiac drugs, for example, huge cardiac drugs, like blood pressure medications, cholesterol medications. So you're talking about all of these seminal studies that have been done. And so I guess I kind of asked as a clarification is that there's different types of studies, right? There are randomized control studies where we actually have placebo-controlled, blinded, and then you have observational and cohort. So women have been involved in some of the different types of trials out there, but not what we would call the standard or the gold standard. Is that what you mean, right?
Yeah, what we require for standard of care and what we use to make our protocols for treatments and develop drugs and put in all the regulations of how drugs are used, all of that requires what you're saying, a different type and quality of research, which women are typically not included because of the expense.
Right.
Yeah.
And so this ban that went in the 1970s, you said it was ostensibly because women were extremely much more complicated, especially when they were of childbearing ages. But this also included people or women that were postmenopausal as well. So they were never involved in any of these studies, even though their hormones are a little bit more straightforward for the most part.
The ban was of women of childbearing age. However, all women already were excluded and remained excluded. So even when women make the change from premenopause to postmenopause, they're still a lot more complex because after all, we're still women and we don't then turn into men and our biological processes and systems don't switch over to the male system. So things are still different for us. And there's still a lot more complexity with the relationship of estrogen and progesterone and how the global neurophysiology operates in relation to those things. It's still an issue. However, you would see even today, more postmenopausal women will be chosen and selected for studies just to eliminate that ebb and flow of estrogen and progesterone that changes on a daily basis, which is almost impossible to control for. It's just extremely expensive to be able to control for that.
What I find so funny here, Kayla, is that even when we look at randomized control data for men, which is what we're mostly seeing, is that these studies still change. The data still changes over time. Because even if you think you're controlling for everything, you are absolutely not, right? And the one thing that Dr. Ted and I and our team at Home Hope always talk about is that you're not controlling for how much sleep these people get. You're not controlling for what microbiota, at least not until recently, what people have as microbiota in their small and large intestines, right? So you can have studies where you see a significant benefit in one group of people, randomized placebo control, but just because they happen to have a certain type of strain in their gut that is more prone to working with a certain chemotherapeutic agent. So it's kind of funny because like we think that we've been controlling for all of these things with male studies, but we haven't, right? At all. And it seems that like every 5 or 10 years, this is what they say when you leave medical school as a physician. They're like, well, everything you learned in medical school will be obsolete in 10 years, right? So, I mean, it's kind of funny now that we're at this point where we're realizing that we completely just didn't even think about women at all in studies because we didn't want to. But then we're also realizing that the research that we're doing now is also sometimes misguided too.
Oh, yes. So we'll talk about that also. So even in the studies that women are included in, when you're researching women, it has to be conducted in a different way. So here's the big mistake that we're making. We are now starting to include women in some of these studies, but we're still studying them as if they are men. So what I have is a checklist that I go through and provide for folks to go through when they want to know if the findings of a study apply to women and to what extent they apply to women. It's kind of like
this. I like checklists. So
so it's like three major checkpoints, and then there's like different subsets under each checkpoint. So the first checkpoint, the like obvious one, is did they include equal amounts of males and females in the study? So that's obvious, right? So that will tell us something, even if they included like 30% women or 50% or 60% women. Each of those percentages means something different in terms of how the results will apply to women. So under that category is also, we have to look at the different kind of demographic data when it comes to women specifically, because women of different life phases are going to be different in the way that you have to study them. So were the subjects all actively cycling, right? Were the subjects all postmenopausal? Were there a combination of subjects? And then how were those different subjects treated? Because the way that they're treated has to be different in order to understand their specific outcomes that are relevant to them. So that's another thing. You have to look is, did they even delineate whether the women were cycling or non-cycling? Then it gets even more hairy and complex, because then it's like, okay, let's say all the women were actively cycling that they included. Let's say they included 50% women and all of them were actively cycling. Okay, great. Were they normally cycling? Were they on hormonal birth control?
Right.
So there's a lot of variation there.
Sure, I can see that.
What does their cycle look like, right? This is another thing that we have to understand. The scientific standard is to use a 28-day model for the hormone cycle. But the reality is that barely any women are a perfect 28-day cycle that repeats perfectly 28 days every month. So even when we make that assumption, which we're making that assumption to save time and money, right?
Of course. Yep.
And to avoid the issues with all this variability. But the truth is that all the variability is there. Every woman's cycle is different. And even from month to month, it might change a little as well. So that's category one. And as you can see, it's already getting pretty complex.
Yeah, it is.
In how we want to treat these different subjects. Then we go into the next category down, which is, how is the data collected? The way you collect data for male subjects is very different, cannot be the same as the way that you collect the data for the female subjects. Now, you can go ahead and collect the male subjects' data at the same frequency as you collect the female subjects' data, but you can't reverse it. So what I mean by that is any study that wants to do a point in time, a single point in time data collection, that cannot be done with actively cycling women.
Got it.
So what actually has to be done in order for the results of the study to be applicable to these women is that we have to account for or control for the hormone cycle phases. So
do you have to be hypothetically testing the hormones as they're going through the study to know where they are, or that's just not happening?
That would be a gold standard, but obviously way too expensive for most folks. So at least you have to be tracking each individual woman's cycle.
Okay.
And then what you can do is you really want to be looking at hopefully all 4 phases, but at least 2 to 3 phases of the hormone cycle. So you have the menstrual phase, the follicular phase, the ovulatory phase, and the luteal phase. And the luteal phase really should be like early luteal, late luteal, right? Different because there's different things happening.
Sure.
So you want to understand, how did they collect the data? If it was a single point in time collection and they did not understand where in the cycle for each subject that data point was collected, already the results are essentially obsolete.
Got it.
So that's the next point, is you want to look at the data collection. Also within the data collection, how long was the study conducted? Because looking at one cycle only, so like a month-long study, that's also not appropriate. You need to at least go over 3 full cycles in order to understand
3 full cycles.
data
Okay.
is
Gotcha.
valid.
Okay.
So that would be like the minimum. The minimum viable would be 3 full months to gather 3 full cycles for each woman.
Part of the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this episode, check out the metabolomics module. This module assesses real-time metabolism, vitamins, minerals, nutrients, what's happening in your cells right now. It's clinically actionable. You can help your patients that are right in front of you optimize their health and see benefits almost right away. Go to homehope.org and save 10% on this module or any modules at HomeHope by using code podcast10 at checkout. Now back to the show. Wow.
So
Okay.
you have to track the cycles of each individual woman to understand what phases. You have to collect the data within each different phase because it changes the neurophysiology so significantly that it's a whole different subject, essentially. You could say every woman is essentially 4 different research subjects over the course of a month. So you want to get data from each of those subjects.
Right.
And then you want to go over at least 3 months to cover 3 cycles. So again, you can see how things are getting more and more complex and very, very expensive now, very expensive. So then we go to the last category, which is how the data is reported.
Okay.
So at the very least, baseline, we want to see that the data is reported at least by sex, by male and female. You would be surprised how many studies are concerned about including the right amount of women, but then they report the findings in total. They don't delineate the findings between male and female, which is a real shame because basically wasted. It's a loss. So how is the data reported, male versus female? Also, is the data reported by cycle phase? This would be the gold standard. Because you're going to collect the data in each different phase over 3 cycles, for the female subjects, you also want to report the findings by phase to see what that variability is. Now, this is where we get into really high quality gold standard care for women. If we were taking into account all these differences that occur over the course of a month and understanding what those key differences and key different needs are for women across the month, then we can really target treatments, not only better timing of treatments within the cycle, but we can also alter and adjust the amounts that may be different in each phase. And this would only be known if we're doing the appropriate and the right research.
Wow. This is intense. And I really appreciate you kind of going through all those stages. I have a couple questions about it. So one would be, are there actually any studies that you know of that have done all of this? And if you do, I would love if we can put them in the show notes. If you know some of the subject lines that we can research, that would be great. Do you have any ones that you've worked with yourself or that have done some really great work using all of these steps?
Yeah. So here's the sad truth. The gold standard in each of those categories, as we were talking about, gets more and more complex and more expensive and more time intensive. There is not a single study that I've come across that has done a gold standard in all 3 of those areas. There are many studies that hit 1 or 2, or they might be hitting all 3, but just like the basic requirement, not what you would want to see. So this is actually really, really concerning, considering the research status that we're at, considering where the data's at and how much catching up we have to do in order to really understand women it's really concerning that the research that we are conducting, that we are including women, is not being done correctly. And so one of my main concerns is there's an initiative that just came out of the White House. I think it was announced last December.
Okay.
And what they are doing is they are infusing the field of health science research with $13 billion over the next 5 years to close this gender gap in health science research. So trying to get more data on women, more studies, including women. But here's the problem. If they do this, are they hitting the gold standard in all of these? Or are they at least checking the first box in all three of these areas? What I'm seeing and what I'm already finding is that they're not. And so are we going to waste $13 billion and not actually create real solutions to the issue?
Yeah.
That's my concern. And so this is where it becomes a real political issue versus just a data or a medicine issue.
Yeah, that's a huge amount of money, but we've known to waste lots more than that just for a political season, unfortunately. Yeah. And what I also think about, and I know you think about this too, Kayla, is that where do most of these studies get funded? Why do most of these studies get funded? It's because there's a drug at the end of the rainbow that this company, a pharmaceutical company, which often borrows money or gets money from the government to fund, that's really where this ends up coming out. Like, you don't get a lot of good data for things that have been around for a long period of time because there's no incentive to study something that's been around for 40 or 50 years and may work for men, but we have no idea really which is the correct women to give this particular drug to. So maybe we shouldn't be giving beta blockers to every female, like during their cycle. Like, we don't know this information, right?
We don't know.
And that's actually quite scary to me overall as I think about it, because I worked in the hospital for years, and then we give everybody the same stuff. Classically, that women present differently with a heart attack, but they may not have like your classic chest pain and things like that. But we treat everybody pretty much the same when they come into the hospital, right? And like, there's so much potential variability that we just don't understand. And you also made me think of a business idea too for you, which is like, can you actually have like an assessment for people out there, women specifically, of course, when they're looking at data from a study, and you can say like, this study is 0% applicable to you. This is like 20% applicable to you. I'm sure you've thought about something like this.
Yeah, I have my own little scale that I use like personally and with my colleagues and in the field and wherever I do research to say where we are on the scale of gold standard women's health research. However, it's a really good idea to kind of like certify this and create it as the standard that we're using when we consider doing research, especially when we want to do research that contributes to the field of women's health. So it is a great idea and something that I will actually be thinking of and pitching as I meet with different politicians and government organizations. Right.
Because then you can be like, when somebody's looking at like a new study design, or when they're looking at giving some of this ridiculous amount of billions of dollars to this company to make this study that's going to be inclusive and whatever, all the buzzwords that people use to get themselves studied, but actually looking at the study design and saying, you know what, this study design, it's about, of these major pillars of these checklists that I've created, this is only going to fulfill about 10% of that, right? And I think a big part of this is like, who can do this in the sense, like, as a researcher, are there researchers out there? Are there ways that researchers are getting trained? And I know you have some training that you do as well to like help people understand who they need to hire on their team to be able to do this, right? Because I think that's probably a huge vacuum too.
100%. And even though there are a lot more women in the STEM fields now, there are a lot more women researchers and scientists than there's ever been. There's still, the majority of them are men. And so a lot of these things are not even going to be in a male consciousness awareness, right? Because they're not things that you have experience with, and you don't know what you don't know, right? But I do want to go back to what you were talking about before with the pharmaceutical companies and funding, and how these drugs end up in our protocols and how we use them and what shows up in our actual hospital settings and clinical settings. So an example, like a prime example of this, was a big part of the catalyst of me transitioning from being a general health scientist to focusing specifically on women and working on closing some of these gender gaps, was during my tenure at CDC.
When I met you. Yes. Yeah.
Yeah. I was working, one of the projects I was working on, I worked on many global health initiatives. And one of them was a global cardiovascular disease program, essentially. And the countries that I was involved in and leading the clinical interventions and setting up these protocols and systems and getting them the resources within the clinics for heart disease treatment were Mongolia, Brazil, and Africa. These 3 countries, what we did essentially is we, based on research that had been previously done with CDC and WHO and some other global partners in cardiovascular, they took that research and developed protocols. And then the protocols were specialized for each area that they were going to be implemented into a series of clinics within each of these countries. So as we brought these protocols into each country and we were setting up the clinics and we're setting up the systems, they're all using these standardized protocols. We're providing the drugs for the treatments. We're providing the resources to the clinicians and all of the systems and processes that they're supposed to follow and all of that. So what happens is after a couple of years of putting these things into place and the interventions are well underway and we're collecting the data along the way to see how well these systems are working to prevent or reverse cardiovascular disease, or at least catch the disease before it turns into a heart attack or some life-threatening event. What we were seeing is after a couple of years that the male patients were all pretty much improving. As if we look at the general curve, right?
Sure.
The general curve, the male patients were overall showing improvements, whereas the female patients were going the opposite way. They were either not improving or getting worse based on the treatments that were provided. So this is where I started getting curious and wondering, why would there be a difference between the male patients and the female patients when we're providing the kind of gold standard of care based on the research? Like, we've done a lot of research. This is based on like 50 years of research. It's the gold standard. It's the best drugs. It's the best protocols that are proven to work. What's going on? So I started going back and looking at the research that had been used to develop the protocols. And I noticed that all of those studies had male subjects only. And so I'm looking back, going further and further back, and it's all the same thing: male rats and mice, male human subjects once it got to clinical trial. So that was quite concerning and shocking. So then I was looking for any clues of why the disease progression and outcomes of treatment would be different for females, because maybe it's not a big deal that all the subjects were male. I wasn't sure at that point. So I went back and I started pulling out all my old epidemiology textbooks and public health textbooks and started looking for anything that might give me a hint of what was going on here. And that's when I had the real aha moment that was quite shocking. And that was that all of the figures within these books, so biology textbooks, epidemiology textbooks, neurology textbooks, all of these things, every model within these textbooks were male models, except for the exception of only one area, which was reproduction.
Right.
So this is where I really started to become concerned. And I'm all the way at the end of this in the clinics, seeing negative health outcomes for women and understanding that we have no clue if we're doing the right thing for women. And in fact, in this case, we're certainly not.
Yeah. But also you were you're at the CDC, you were seeing this happening in real time. And I'm sure there's a lot of questions talking about it internally. Like, what were the internal conversations about that? And were there any ideas at the time as to what you guys could do differently or what needed to be done differently? I know we've talked about a lot of things that we think need to be done from a research perspective now, but was there anything happening at the CDC to try to address this or to think about ways to address it?
Well,
Or that's why you left and said, peace out.
It's so this was the beginning of the end.
Yes. Got it.
At CDC for sure. Yeah. Even though I got to do really interesting, amazing work there that taught me how to be the practitioner and scientist that I am. Mm-hmm. When you're working within a government structure, right. Everyone knows that it's a lot of bureaucracy and a ton of red tape. And the issue here was that this is a program that had started 30 years before I even showed up on site. And it had probably billions of dollars that led to where we were, not to mention all the money that we had poured into the infrastructure of the clinics, the money that we had poured into the resources that were needed, the drugs, the trainings, the everything, right? So at this point, we're talking about a multi-billion-dollar investment, not only from the US, but also from all of our other global partners that were involved and the country partners. So, the ministries of health in each of these countries and all of that. So we have a lot of stakeholders who have invested and are betting on this working.
Sunken costs are gigantic, right? So they spend so much money doing things one way. Yes. It's very difficult for them to say, we've done everything completely wrong and we've misspent three quarters of that
nobody was willing to admit that at that point. So the problems that I was presenting and bringing up were too big to take a bite out of. They were too big. While they were definitely concerned that the outcomes of women were not as good, and they were concerned about what I was presenting, and there were definitely a lot of questions and interest in finding a resolution, the problem was just too big, and there wasn't a good starting place that they felt, that any of these partners felt that they could actually make a change. It's essentially the machine was too big.
Understood. Yeah.
Had I been working just with one of the clinics, or had I been working even just maybe with one of the country partners, and it wasn't all these other global partners involved and invested, it could have been a different story, and we could start to make some of these changes. But to say that the whole infrastructure that we have built this billion-dollar system upon for the good of humanity and health and healing is all a farce, that's a little too much for people to accept. And it's too big and too nebulous to feel like you can do anything about it.
Yeah. Well, I mean, I totally understand. And when you have these big machines, it's very difficult to just be a small cog in that. I know that's why this is the beginning of the end for you, that you're leaving the CDC, you're finishing your PhD and doing the work you're doing now. And I just think that it's such a huge issue, right? And we've talked a bit about this in so many different realms. I think the other piece I wanted to discuss is just on being a professional, being a female health professional and being in the world and trying to help people. And what are your thoughts on how this ecosystem is developing now versus where it was? And because I know you have a lot of female colleagues and male colleagues that, like me, are trying to understand this as well, because I have lots of female colleagues that I work with, of course. And in my practice as a hospitalist physician, what I trained in, I think about 3/4 of them are actually women overall. Yeah. And then, of course, I have 3 girls and they're growing up in this environment. What are some of your thoughts about all of those kinds of things happening now and kind of where you think things are going to go, or the future or present or wherever you'd like to take that?
It is interesting that the medical field is the field, and the field of health too. So when I was at CDC, the vast majority of folks working there were women.
Yes, we're women.
When you get into the higher leadership positions, it still ends up being the same as it is everywhere, where it's more male centric. Right. However, generally, there were a lot more women working in the field of health than men, and in the field of medicine than there are men. And at the same time, we as a society know very little about the female biology, how it's different, how it works differently. So even though there are mostly women working within this field, we don't cater the field to women because of the blind spots that we have. So for instance, and something that you can relate to is when we go through medical school or any of the PhD programs or medicine or research or any of these programs related to health, there is no focus on the differences between males and females on a biological basis. Everything is taught that it's all one thing.
We have a brain, we have hormones,
we have human,
Except we're talking about the menstrual cycle. That's it, right?
Exactly.
Right.
So the only difference is reproductive health. And so what has happened is over time, women's health has been relegated to reproductive health. And that's only one aspect of it. Whereas women are a completely different biological ecosystem, a different brain, nervous system, cardiovascular system, respiratory system, musculoskeletal system. Everything is different in the way that it operates in a female body versus a male body. And this is what you were talking about in terms of like how women present with different disease, how we need to create different identifiers for different diagnoses for males and females. We're now starting to understand that there are differences. However, we still don't know exactly what those differences are. We have a good starting place and we're starting to understand that. And that's a lot of what I teach is what are those key differences that we are learning and understanding now. And so we've come to this place where we are in this female dominant workforce. Centered. Yeah. Female dominant workforce in healthcare and medicine. However, it's still male focused because of the information that we have.
Right. Understood. So I think it'd be really interesting. Now, this is going to be very rudimentary because there's so many aspects to this, but I think it'd be great as sort of highlighting in some of those major systems that you just described, some of the major differences between men and women. I know this is also going to sort of dovetail probably into the idea that women are 4 different people throughout their menstrual cycle. And if you want to start that way and then kind of throw in like the differences in brain, heart, respiratory system as you go, that would be compared to a man, whatever you feel is best is the best structure. But I think it would be helpful for the practitioners that are listening because as you said, I had zero training on this in medical school, except for reproductive health and how female hormones change throughout the cycle. That is it. We didn't talk about any neurologic differences, any cardiac differences, zero, I don't think. So I think it'd be however you want to frame this, but like if you're a practitioner, if you were talking to practitioners and giving them an overview here of like the major differences and the major things to be thinking about, when you're working with women, how would you approach that?
Yeah. So one of the things that I'm working to establish within our scientific community, our medical community, and healthcare community is understanding that there's a biological rhythm that is the major difference between males and females.
Right.
So the male biorhythm is a 24-hour repeating system where all of the biological processes related to the heart and the brain and the lungs and the muscles and the metabolism and all of these things are on a repeating 24-hour system. So essentially what it means is from day to day, men tend to be very consistent on a biological level. Like the same processes are happening and repeating.
Right.
As every human, there are shifts that happen over long periods of time with any person, right? Male or female. But what I'm talking about is generally from day to day, there's a consistency, a biological consistency with this 24-hour repeating system.
Right.
And in the males, that's really driven by the adrenals. So it's kind of our sleep-wake cycle. It's driven by the rise of cortisol in the morning to the rise of melatonin in the evening. And the biological systems tend to follow that rhythm generally. In the female system, of course, we still have sleep-wake hormones. We have that cortisol melatonin rhythm. And we also have a more dominant hormonal system that sets the pace of the global neurophysiology. So again, all of those systems, the cardiovascular system, the nervous system, the musculoskeletal system, the metabolism, all of these things are driven and set on a different pace. And that is the ovarian hormone cycle, which is the key driver or the pace setter for the female biology. And so what that looks like is over a 28-day period-ish, right? Everyone is a little different. Over about a 28-day period, women are changing in all of these processes, little by little, shifting each day. And significantly, if you zoom out, in each hormonal checkpoint where the hormones of estrogen and progesterone are very different across that cycle. So that's how we've split up the different phases of the hormone cycle, is where the significant hormonal cutoffs or shifts are. It's not really cutoffs because they all kind of bleed into each other. Where are the big differences? So when we look at those places where the big differences are, those 4 different phases, then we see that all of those biological processes operate very differently in each one of those hormonal phases in women. So that's why I say, because there are kind of those big 4 hormonal checkpoints, that women are physiologically 4 different women over the course of the month, also means that they're 4 different research subjects. It also means a lot more expensive, complicated, confusing, right? So there's there's more moving parts, essentially, because we have a 28-ish day rhythm versus a daily, consistent, repeating rhythm.
And so as these cycles are shifting, as you're shifting from different phases, you're becoming different women, as you say, what are some of the main sort of physiologic ramifications of these when it comes to some of our major organs? Now, certainly most of us understand, I think, that are listening, like the hormonal cycles themselves, in the sense of, so I don't think you don't have to belabor that if you don't want to, but if it helps you to help demonstrate what's happening in like a female brain, for example, versus a male brain at certain times, and that's fine. But however you think would be best, but like, central, like major organ systems, major differences, those kinds of things would be really helpful.
No, absolutely. This is kind of the core piece that we're missing in our medical training, in our research training, health training generally, that really everyone needs to understand, so we understand what we're working with here. So we'll just start with the menstrual phase, which we'll just call phase 1. So during the menstrual phase, hormonally, what we're looking at in terms of estrogen and progesterone, which we have found to be like these key global drivers of female physiology, estrogen and progesterone are at their lowest level during menstruation. So we'll call that phase 1. When estrogen and progesterone are at their lowest level, there is a global downshift of all these different physiological processes. So what I mean by that, I'll just give a few examples, is the female metabolism, or the conversion of macros, so fats, carbs, and proteins, through the citric acid cycle and generating ATP, which is fuel for the cells. That whole process slows down in this low hormonal phase. So what that looks like in reality is women have less energy during this phase, which any woman can be like, oh yeah, duh, that's true, right?
Yeah.
But even this is something that's not considered in medicine. It's not something that we're taught. But it is something that's actually really extremely important, especially when you're considering medical intervention and lifestyle changes and things like that, right?
Sure.
Understand what that looks like.
Sure.
At the same time, there's a total neurochemical shift that happens in each of these phases. So in terms of another system that's impacted is the brain. And the female brain is probably my favorite subject, which is something we could have a whole podcast just to talk about that, because it is so complex and amazing. And there are a lot of differences that we're learning and understanding now. But what this looks like on a neurochemical basis is that in that low hormonal state, our excitatory neurotransmitters are subdued during this phase specifically, and even our downregulatory neurotransmitters are not working as strongly. So I'll explain how that is different in a higher estrogen state and in a higher progesterone state, because each one has its own action and reaction within the body to change these systems. So from phase 1, we go into phase 2, which is the follicular phase, which, as probably most of the people listening to this know, encompasses the menstrual phase, but we're going to call that a separate phase because of the hormonal difference. So the difference in this phase is that estrogen only is rising to a peak. So as estrogen rises to a peak, what we find is that the female metabolism increases during this time period as estrogen is rising. So positively correlated with higher levels of estrogen. Now, specifically for estrogen, it also upregulates our excitatory neurotransmitters. So we're talking about epinephrine, norepinephrine, glutamate, and even serotonin and oxytocin, which are more of like regulatory neurotransmitters versus excitatory. But all of these kind of mood and mental energy neurotransmitters are upregulated as estrogen rises to a peak. So what that translates to is because the overall metabolism, the fuel for the body is increasing, and we're getting a boost in these excitatory neurotransmitters, women tend to, as estrogen rises, feel better. They tend to have more energy, a better mood, more stable mood, and they also have a higher capacity for stress. Their nervous system becomes more
resilient,
more malleable, right? The stress bucket, as some say, increases as estrogen increases.
Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision-dosed, physician-formulated, and pharmaceutical-grade formulas in the form of a buccal troche. For this episode, check out Trocom. Kayla is a huge fan of Trocom. It helps you relax. It takes off the stress and tension. It helps you wind down. It helps quiet your mind. It contains a combination of kava, CBD, and CBG, both non-psychoactive cannabinoids, along with something called nicotinol GABA. It's a vitamin B3 attached to a GABA to get across into the brain easily, to relax you in about 15 to 30 minutes. Take it at the end of the day to wind down. It's much better than alcohol or marijuana, which contains THC and might ruin your sleep. Go to transcriptions.com and save 10% on your order by using code POD10 at checkout. Now back to the show.
Then we get to the third phase, which is the ovulatory phase. And this is what I actually call the bloom phase, because this is when women typically feel their best outwardly, like in the way that we all want to show up in the world on a general level, is that we want to have energy. We want to be in a good mood. We want to be happy. We want to be social. We want to be out there. We want to be connecting, right? So this is the best phase for that, because we have all of this beautiful cocktail of excitatory neurotransmitters and mood stabilizing neurotransmitters. And at the same time, we have more energy because our metabolism has been increasing during this time. And so it's kind of the time when women will be more outwardly focused. They'll be more socially oriented. And then there's a whole other piece around our cognitive states shift as the hormone shifts. So one of the things that we are now understanding is that as estrogen rises, so does a woman's emotional intelligence. So the way that we connect with others and the way that we interpret and process not only our own emotions, but other people's emotions, the capacity for that increases as estrogen increases. So there's a lot of things like that. So then we go from phase 3, ovulation, into the luteal phase, which is actually the whole back half of the cycle. It's the last 2 weeks. And technically, a lot of studies will separate that into early luteal and late luteal. But the thing that where we collect the most data and have the best understanding is the mid luteal phase, which is when progesterone has peaked and estrogen is low. So it's swapped. Okay. So over here, estrogen was high, progesterone was low. Now we flip-flopped. Yep. Progesterone is high, estrogen is low. So then we look at what is the neurophysiological state there. And what we find is that, yes, in fact, the metabolism has slowed again, and the excitatory neurotransmitters are calming down again. However, a different shift is happening. With the peak in progesterone, what we find is that there is a peak in brain-derived neurotrophic factor,
BDNF,
which increases, BDNF, which increases neuroplasticity and neurogenesis. Plus, there is an upregulation of our downregulatory neurotransmitter, a master downregulatory neurotransmitter, GABA. So what this translates into is, and also why I call this phase the brainy phase.
Yeah, it sounds like the creativity brainy phase. I like it. Okay.
Yeah, it's kind of like the learning phase, the brainy phase, because what this translates into is that there is greater memory consolidation that happens during this time. There's a greater ability for more restful sleep and for the brain to regenerate and recover. And so there is a benefit here. However, there's a little bit of a caveat and a little bit of an opposite thing happening as well. So at the same time as we're getting these brain benefits and this kind of like down regulatory support for the nervous system is becoming more sensitive to stress at this time.
Okay.
So there's kind of like, if women want to really be able to leverage and benefit from this brainy phase and get the benefits of progesterone, the neurochemical benefits of progesterone, they have to prioritize getting restful sleep is number one. They have to prioritize giving themselves opportunity for that down regulation to occur, which sometimes we're not afforded that opportunity within our roles in society and the responsibilities that we have.
Yeah, our months aren't broken up into 4 separate categories as far as I can recall. So we just have weekdays and weekends, right? That's
it. So, if it was the opposite, if let's say starting with the advent of agriculture, women were the ones tilling the fields, and they were the ones who were the property owners, and they were the ones who led the Age of Enlightenment, and they were the ones doing the studies, and they were the ones who were being researched and collecting data and driving the economy and running the workforce. Then we would have the opposite thing where our world would be set up on a month-long, 4 different week basis, and we would operate in that way where different things would occur at different times.
Yeah, but women are all cycling at different times anyway, so that would be, it's like you'd have to be all like very much individualized to that individual person, right?
That's what it has to be. So when you unravel it, and you get down to where was the core mistake made, and you want to build that back to create a truly inclusive environment for women, societally, work-wise, within our economies, is we have to provide flexibility.
Got it.
Flexibility will equal inclusivity.
I love that as kind of a good way to circle up on all of this, right? Because I think that's the key, is that to make sure that we're all supported, men and women together. And I think that men also need more flexibility than they often realize too, but I think not to the significant degree because of what we're talking about here that women do. So I think that would be sort of like your moral of the story with all of this, is that there needs to be, when it comes to work and when it comes to life in general, there needs to be more flexibility on how we operate in society.
Absolutely. Yeah. More flexibility. And all of this starts with awareness. What has been done has been done. And what we're working with is the reality in this moment today. So what we can do is we can be more aware. We can understand what our limitations are, especially as clinicians and practitioners and researchers and scientists who are leading in the field of health. If we can admit that there are things that we don't know yet that we need to know, and that there are differences that we don't fully understand. However, there are some of these components, like what I laid out here, that we do understand, and there actually is quite a lot of research supporting these differences within each of these hormonal phases, so we can start to put that puzzle together. But we do have to take with women that like N=1 approach to health. Whereas for men, because we have so much robust data on male bodies and male health and male neurophysiology, we can be a little more standardized and generalized with men than we can with women, because we just don't have the data and the systems to be able to do that yet.
Right.
So each woman has to be treated as an individual case, and understanding her individual biorhythm. How long is it? What is the quality of it? Are there things that are influencing it, like hormone replacement therapy or adrenal burnout that can have an effect on these things? So we really have to look at each individual case and also understand that not only is there individual variability, but within the individual, there's variability when it comes to women.
Yeah, and that's what I was actually going to go to, sort of to wrap up a little bit here, is that the N=1 aspect. Every woman is going to be different.
Yeah.
What are your recommendations, either from a practitioner recommending it to their patients to start getting a better handle on what that is, or even just like direct to consumer kinds of things? Like, what are your suggestions for women when they really want to start taking, more, like be more empowered over, their cycle and understanding some of these rhythms in more detail?
So the very basic thing that every woman can do, whether they have any kind of like tech wearable or if they don't have to have anything like that. Or if they have some kind of app on their phone that tracks their cycle for the actively cycling women, for the women who are postmenopausal, if they don't have a wearable or anything like that, what all women can do is start with a kind of journaling tracking methodology.
Okay.
Which is what I teach to practitioners in my education programs. But for
Right.
individual women, essentially what you can do is you want to measure some of these variables that we know change in a way that resonates with you. So we talked about how the nervous system is more sensitive or less sensitive, for instance, within certain parts of the cycle. If you have a wearable device, no matter whether you're a postmenopausal woman, perimenopausal, actively cycling woman, pregnant, whatever it may be, you can track certain metrics and follow their rhythms across a month-long period to figure out where you might be with your biorhythm, not just your cycle, but your biorhythm. So for instance, with the stress or the stress sensitivity of the nervous system variability, one of the best metrics that we can look at is heart rate variability and how heart rate variability changes across the month for women. When the heart rate variability is lower, the nervous system is showing that it is a little more sensitive to stress or it isn't as resilient, and it might take a little more rest and recovery in order to get to your baseline. And then at other times when the HRV is naturally higher, which you'll see these curves if you look over several months,
Sure.
you'll see the general curve. That shows that there are certain times when it's always a little bit lower, and there are certain times when it's always a little bit higher. And sometimes it's not just a little bit. Sometimes it's actually significantly higher and significantly lower. But the swings are definitely there and become obvious when you look over time. So another thing that women can do is, let's say they don't have a wearable, but they want to start tracking and figuring out where they are, whether they use a cycle tracking device or app, doesn't matter. What they can do is create personalized Likert scales for themselves. So what I mean by that is, let's say energy level is what you want to measure, and you want to do a 1 to 10 scale. 1 is very low energy, 10 is super high energy. And what a woman can do is just rank herself 1 to 10 each day on where she is energy level. Then you can take those numbers and actually plot them on an axis where the bottom is your day, so day of the month, or from whenever you started tracking. It doesn't have to be in order yet. You're just going to say day 1 of tracking, and you're going to go all the way to day 35, especially if you don't know how long your cycle might be.
Sure, yeah.
And postmenopausal women can do this as well, because what we find is even postmenopausally, there's still an ebb and a flow. So that's also a little bit of a mystery and interesting. And then on this side, you have your 1 to 10 scale. And so you can plot that, and then you can actually start to see the patterns. This is kind of a really game-changing thing, and it's so simple, something that any woman can do without any special device or anything. And you can do this for any metric that you want to measure: quality of sleep, how well rested were you when you woke up. I'll scale like 1 to 10 or 1 to 5 if you want to make it smaller. You can also do things like happiness or irritability or mood or appetite, or, there's all these different things that you can do.
Right.
And you'll start to see these patterns. And from that, you can understand where you are within that biological rhythm.
I love it. Oh, that's amazing, Kayla. This has been fantastic, and I really do appreciate you spending some time. I think my last question for you, and we ask everybody at the end of the podcast, what are 3 ways that they can live smarter and not harder? And in this world, whatever, it could be in your areas of expertise. It could be how to rent an Airbnb well, because I know you have one of those that you do. Whatever you think is best. But I think it would be great to kind of sum up, if you have any good ideas for those listening, how they can live smarter and not harder.
Yeah, I think one of the big things that I'm seeing across the globe, and especially in the field of policy and public health, is a lack of acknowledgement of differences. So we have to not only accept and acknowledge that there are key differences between males and females,
Mm-hmm.
but we also need to embrace those differences. And part of embracing those differences is learning and understanding what they are. I find that in our society today, with political correctness and all of these ethical issues, which are certainly a high concern and need to be considered, we have tried to make everybody the same. We've tried to level the playing field in a lot of ways, which sounds like a good idea at the onset. But really what that means is we're trying to make everybody the same, and we're not. And so what we end up doing is disempowering the folks that don't fit the standard model that we're trying to work with.
Beautifully said. Yeah.
So I would say that's the biggest thing, is understanding and embracing our differences. For women specifically, and for their male counterparts, whatever that is, their fathers, their husbands, their coworkers, their whatever way that males and females are interacting, is to understand that there is a very different biological rhythm at play, and that it is a different cadence. And what this requires is really one thing. Let's provide flexibility, right? Because that doesn't take anything away from one to the other. All it does is expand. It truly does expand the playing field to be more inclusive for everyone if we can be more flexible and allow individual variation in the way that we operate. So what that could look like is offering a little more flexibility in schedules, maybe even taking our outcomes and expectations from a daily or a weekly basis and putting it into a monthly basis so that women can allocate their time and energy and skill sets in the smartest way at different points throughout the month.
I love that. Yeah.
This would be a smarter way for us to operate as a society.
Yeah. Sounds like a very smart way. Yeah.
Yeah. I don't know that I have a third one, but I think those would be my main recommendations.
Those are fantastic
ones.
And I love it because they resonate with me very much overall. Certainly as a husband, as a dad of 3 girls, and working with lots and lots of female colleagues for many years as the minority in my field, really. And so in our field, I think they're fantastic. So Kayla, if people want to learn more about you or about, I know you have a training program for practitioners, where can they find that info?
Yeah, thank you. If you go to my website, it's called Biorhythm.com, or you can find me, Dr. Kayla Osterhoff, on the socials. And then there are links to my website there.
And so your training is for practitioners. What's the general?
Yeah. So I have a training that I do once a year for health practitioners. And that can be anything from a health coach to a medical doctor, OBGYN, therapist, psychologist, psychiatrist. I've had all and continue to have all through the program. And really what it is, it's that basic female physiology 101 that we never got within our training that we really needed to have. So it gives the basics of all of this, the differences in female neurophysiology and how we need to take these things into consideration in our health practice, whatever that may be.
I love it. It's so great to talk to you, Kayla. I've been here for part of your evolution, leaving the CDC, creating your own practice, creating trainings, now doing the work with governments and politicians and the vaccine. So keep up the fantastic work. And thank you for being here, and hope to see you sometime again in the future in person.
Yes, me too. We got to make that happen. Thank you so much for having me.
Okay. Take care, everybody. Have a great day. Thanks so much for listening to another episode of the Smarter Not Harder podcast, where we give you 1-cent solutions to $64,000 questions. This is a fantastic episode to record with Dr. Kayla Osterhoff. She's just a wealth of information, especially about women's health and all the challenges, nuances, complexities that go into this. I learned a lot here. I hope you did too. If you like our podcast, please don't forget to like and subscribe below. Please share the love about us, about Home Hope, about transcriptions. We hope to see you next time. Take care.